So we're going to get started on the next session. I'm Curtis Rogers. I'm one of the old guys around here. If you want to come to a titillating session after this one, you can come to the founders session. You can see a bunch of old people talking. It'll be kind of like a presidential debate. So I think we're a little more with it than our candidates are, though. What a mess. Okay. So our next speaker is going to be Dr. Billy Bennett. Billy is an authority on GI issues, and that's what this session is about, gastrointestinal disorders. Billy is a distinguished pediatric gastroenterologist. I told him I would be nice introducing him. He's an associate professor of pediatric gastroenterology, hepatology, liver, and nutrition, and scientific director of the CTSI Patient Engagement Corps at the Indiana University School of Medicine. I'll have to admit I had to look up what CTSI was. As like the government, medical schools like to use a lot of abbreviations. Clinical and Translational Science Institute. In other words, taking it from the lab, developing a treatment, and giving it to the patient. So trying to go from the bench, as we call it in the lab, to the bedside. He's also a dedicated father of a daughter with Phelan-McDermid syndrome, and she's here with us today, too. He's driven by a personal and professional commitment, and he has developed programs to address the subspecialty needs in gastroenterology of children with complex developmental issues. His research focuses on using health information technology to enhance evidence-based medicine, understanding patient and family preferences related to the use of immunosuppression, and analyzing large clinical data sets to improve patient outcomes. He's a member of PMSF's medical and scientific advisory committees. He's one of the few that's on both of those things. He's contributed actively to Phelan-McDermid syndrome clinical consensus guidelines, which you saw this morning that Sid presented to us. He also leads the NIH-funded CANDID Consortium. Does anybody know what CANDID is? I had to look that one up, too. Billy knows what it is. I know now. Consortium for Autism, Neurodevelopmental Disorders, and Digestive Diseases. So that's what CANDID is. It's focused on those GI disorders that occur frequently in neurodevelopmental conditions. In this session, Billy's going to share his latest research, diagnosis, and treatment options for GI disorders in PMS and valuable resources available to families. I can tell you I personally contacted Billy with emails frequently about patients with PMS to ask about their GI issues, and he is very responsive to trying to help educate our local GI folks and helping us to come up with a plan for managing the gastrointestinal issues in a particular individual. And we know those are going to be different in a lot of different kids, so we have to have somebody who's got a flexible approach, and Billy has that. So without further ado, Billy, come on up here.
Thank you, Curtis. The very first person that I watched, this is my second conference. The first one I went to was in 2018. And the very first person that I watched talk was Curtis and Katie Phelan. And I didn't realize at the time that I was listening to probably the two experts in PMS. and I've just really enjoyed being part of the community. It's very empowering. And it's just a coincidence that I happen to also talk to people about poop. So this is what we're going to do today. And I want to sort of talk about the poop emoji for a second. So the poop emoji is smiling and happy. And the reason that he is so happy is because he is the perfect poop, according to a gastroenterologist. We often tell people that we want like soft serve ice cream or mashed potatoes or like a ripe banana. And this guy embodies it. And that's why he's so happy. So the title of my talk is Gastrointestinal Problems and Autonomic Dysfunction in Genetic Neurodevelopmental Disorders. But really what that means is, hey doc, my kid's pooping problems are utterly taking over my life. Please help. Because that's the end result. And so that's mostly what I want to talk about, is how the nerves in our kids' bodies being out of whack contribute to a bunch of different GI symptoms. And I want to share with you some data that we've gotten. Many of you participated in this nationwide survey that we did a couple years ago for CANDID. And it's the most important thing to remember is that of all the disorders that we sent this to, PMS was #1. So just saying. And I've talked to other foundations and shown them the same data and shown them that we were #1. So that's the most important thing to take away from this. So I have no personal conflicts of interest. I do receive funding from the federal government related to these things. I'm actively on data safety monitoring boards, and I serve as a consultant for federal projects. Okay, so this is probably the most important slide. I think there are 4 things that are out of whack that cause problems and cause GI symptoms in PMS. And this isn't something, it's important to remember, this isn't something just isolated to PMS. This is something that happens across most genetic neurodevelopmental disorders. So the first one is that because the nerves either aren't functioning like they should or they're not formed quite like they should, they have abnormal communications between the brain and the GI tract. And there's a ton of nerves that their only job is just to have the brain talk to the GI tract and vice versa. The other issue is that there's this entire nervous system that just exists within the stomach and the intestines. It's called the enteric nervous system. And there are as many nerves in that system as there are in the spinal cord. So it's this really, really innervated organ. There's a reason that, like, when you're nervous about something, like let's say you have to give a talk in front of hundreds of people, that your stomach tends to bother you. And it's because it is chock full of nerves, and there's a ton of connections between that system and the brain. The third thing that's contributing is all of the muscles around the GI tract. So you're basically just like your GI tract is just this big kind of sack of stuff inside a muscular container. And when you have low muscle tone, like most of our kids do, then your ability to squeeze that like you need to in order to poop, to relax it when you need to in order to poop, that is impaired as well. And then the fourth one, and this is where I think a lot of doctors overlook the important aspect of it, is that whenever, especially if you have autism or ASD, you tend to have different ways of processing information. So let's say that a typical person gets a signal from their colon that it's time to poop. Their response is, oh, yes, I am now going to walk to the bathroom and I'm going to poop. And if you're a middle-aged man, that means after dinner, every single night, in theory. And so but this behavioral response is different if you've got some short-circuited wiring related to your response to sensory information in your brain, which almost everybody with ASD does. Then your response you may not be interpreting that information the same way that you or I would. And I think all of these things together are happening typically all at the same time in different degrees in everybody. But all of these things are contributing to the GI problems that we see in our kids. Okay, so this is my outline for what I'm going to talk about. So the first one I'm going to talk about poop, and the second part I'm going to talk about throwing up. The approach is fairly similar to both of them. I'm going to go over two different disorders. For the poop part, I'm going to go over something called functional constipation, which represents most constipation. And for the vomiting, I'm going to go over something called cyclic vomiting, which is a particular pattern of vomiting that's definitely more common in PMS. But the approach that you take to both of these doesn't necessarily need to be these problems. If you're constipated, the stuff I'm talking about with constipation, should be helpful. And the same thing with vomiting, is that the approach to vomiting should be helpful, even if you don't meet the strict criteria for these diagnoses. Okay, so poop. Like I said, this is an important time to remember. This is excellent poop. This is goal poop, and that's the reason that he's smiling. If I had any power with Apple, I would also have an alternate frowny poop emoji, and he's like, if you guys are familiar with the Bristol stool scale, he would be way over on the right, be like a 7, like this hard rabbit pellet type poop. That proposal has not yet been accepted. Okay, so just to kind of give some reasons why I want to talk about constipation. So this is from the CANDID survey that many of you participated in a couple years ago, that constipation has about double the rate of other GI problems or other GI symptoms. And this is, and it's obvious that all of these are a problem, but constipation really seems to dominate. So I wanted to drill into why all of these things are happening. Like, what are the specific elements of the GI tract that are out of whack, and what can we do for each of those elements in order to make constipation better? So this is a diagram of the colon, which we can all acknowledge is the most important organ in the entire body. The colon and the large intestine are the same thing. It's the end of your digestive tract, and its entire job is just to dry out your poop. And that's great if it just spends a few hours in there. But for a lot of our kids, it spends a lot longer time than that. It gets way too dry, and then you can't get it out. And then all kinds of other things can happen from that. So the first part of it that's important is the enteric nervous system. So in the colon, this creates these things called mass actions, where it's squeezing at different parts of the colon to move the poop along. And so this part can get messed up if you have to take narcotics, for instance. So if you have a surgery or a procedure where you need to take any kind of opiate, that will slow down. A lot of other medications, especially if they're what are called anticholinergics, they can make your enteric nervous system slow down, make your poop slower, and then it can get much drier in that process. The next thing are what we call afferent signals, and this is one of my least favorite words in all of medicine. It was clearly invented by neurologists. I apologize to the neurologists in the room. But if they go towards the brain, they're called afferent, and if they go away from the brain, they're called efferent. And I have to stop and just like, affect and effect. You just hope that Microsoft Word corrects it for you. I'm pretty sure I had this one right. Afferent, the signals that are coming from your intestine going back to your brain. And so if you've got abnormal nerves, like if SHANK3 is, that there's not enough SHANK3, then that nerve transmission can be out of whack. And so you may not be getting the signals up to your brain. And then once they get to your brain, your behavioral response, like I talked about earlier, that could be completely disconnected with what actually happened at the source. And then you have all these pelvic floor muscles that are supposed to hold things in. And just to backtrack a little bit, so the thing that we would do for this is that we would give medicine that speeds up the colon. And I'll go over that in a second. They're called stimulant laxatives. What we would do for this is we would work with like an ABA therapist, for instance. So any other time that you would want to improve response to sensory stimuli. So like ABA therapy, talking to a BCBA, that kind of stuff. And that integrates that sensory part of it with the behavioral response. And then we have the pelvic floor, which is, needs to be more coordinated to poop. And just like most of our kids go to, see physical therapists for the rest of their body, you can go see a physical therapist for your pelvic floor. And I will talk about that a little bit more in a little bit. And the end result, if any of this happens, any combination of these things happen, if you don't poop when you're supposed to, if you can't poop when you're supposed to, if your colon isn't moving like it's supposed to, if your response to that sensory information isn't what it's supposed to be, the end result is the poop hangs out there too long and it gets hard. And then the only way to deal with that is to give somebody something to make the poop soft. So let's talk about all the things that you can do for your poop. So this sort of approach I'm talking about is not really what most clinicians use. We're taught to find one explanation for a problem. It's like, oh, well, why isn't he pooping? It's like, well, it must be this medicine, or it must be that he needs to eat more fiber, or it must be that she needs to stop holding her poop. But I think in PMS especially, the cause is probably lots of different things happening at once. And rather than looking for one thing and treating one thing or trying one medicine at a time, I think we need to change our approach to where we, from the beginning, try and attack this from multiple different angles. And, since all of these aspects that I showed you, they're all related to how the nerves work. And we know that the underlying problem in PMS is that the nerves are misbehaving. Why are we just trying to treat one thing at a time? Why are we doing one medicine at a time? And so my draft term for this is called the perfect storm approach, but I'm totally open to other ideas if any of you guys think that this is a bad term. So if you have any ideas, come grab me afterwards and we'll copyright it together. We don't really have enough research on this. We need to understand this a lot better before we can convince clinicians to do things differently. Okay, and here's one of the problems. So let's say that you want to diagnose somebody with functional constipation. These are the official criteria. 2 of these have to be true. So straining during 25% of defecations, okay, like that's kind of hard to figure out. Is my kid straining, or is my kid angry, or do they just not want to sit on the poop? What if they can't talk to me and tell me what they're feeling? Lumpy or hard stools more than 25% of the time. I don't know how many of you keep a poop journal. It's pretty hard to have a good sense of how precise is this over time. They can't tell us if they feel incompletely evacuated, usually. Even most PMSers that are fully verbal, they often lack the language complexity to say, yes, Father, I feel incompletely evacuated after this last poop. Cecilia just says, I don't want to poop, right? She's giving me yeah, okay, now she's back to her iPad. So, most of these things are not validated in, most of these things are validated in neurotypical people. They depend on being able to report something, to report a very specific sensation. They depend on really meticulous attention to how often something's happening, often which is really challenging in people that have special needs. So this is not a good way to diagnose constipation in our kids. So the way that I suggest doing it is you just ask 2 questions. Do you poop every day? And is your poop hard? And if the answer to either one of those things is, I had that wrong, sorry, I'm getting old. Do you go more than 1 day between bowel movements? And is your poop hard? And that's a much simpler, easier way to say that you're constipated. I also don't think it's subtle. I don't think any of you who have kids that are constipated are like, yeah, I'm not really sure if he's constipated or not. He's pooped like twice a month, and it looks like an adult's poop. So we need to have better, more precise ways of diagnosing this kind of stuff in our kids. Okay, so what do you do? If you're constipated, what do you do? So the first thing is a set of medications that are called either stool softeners or osmotic laxatives. But a much better term is that these are the mushers. So these make poop softer. Miralax is probably the one that's used most often. Lactulose is used frequently, mineral oil, docusate. Another one is magnesium citrate. That's kind of pretty powerful. And they don't affect the way that the GI tract moves. They just make the colon hold on to more water. So you end up with softer, wetter, squishier poop, which is easier to get out. But the thing to remember is that if you don't want to poop it out, if you want to just hold it in, or if the colon doesn't move it along, it doesn't matter how soft it is. Like, this is more like you always want to make sure it's soft, but that isn't always the only problem, especially with our kids. One thing that people often overlook is that for any of this stuff to work, you need to start out with a clean colon. So if somebody's impacted, or they have a big hard poop ball in an x-ray, or they're having accidents, that usually means that it's time to do a clean out. And so what I do is the same thing that we would do before a colonoscopy, is I want it just squeaky clean. So just lots and lots and lots of Miralax. And then you want to be on something every day so that that your poop stays soft. And usually that's about, in most kids, it's about half a capful, and then the adult dose is about a capful. But I have patients that take, where mom waves the bottle of Miralax over the drink in the morning, and then other patients where they're taking 3 or 4 caps a day. So it really depends on the kid. So the next category are called pushers. So these are the stimulant laxatives. So Senna, Bisacodyl, Dulcolax, X-Lax are the name brands. And these actually interact directly with the nerves and muscles in the colon and tell it to push. And we often use these once we know that the poop is soft. Okay, let's give this a little bit of a push. One reason that people often avoid them is that they're concerned that you can develop dependence. Maybe if you try and stop them, you'll have a little bit of rebound symptoms for a week or two. But for the most part, this isn't like dependence, like you're going to break the colon or something. In the grand scheme of things, all the constipation medicines are like pretty mild. Sometimes they can cause more pain. So like you're telling the colon to contract. So sometimes you can feel that, and it can be fairly uncomfortable. But in general, these are pretty well tolerated medicines. Then we have the rectal medicines. I tend to be a little hesitant to use rectal medicines in kids that have autism, because they already are not super happy with uncomfortable sensations. So then, adding an uncomfortable rectal sensation can sometimes make stool holding worse. But a lot of kids do really well with it. So the 2 different types are enemas, which is just like a bulb of liquid, and suppositories, which is like a pill that just goes in the bottom. Sometimes they're used to liquefy things, like in the case of like a Fleet's enema, it's just saline. And then sometimes they're used to actually stimulate the area around it. It can be helpful for a lot of kids that have a hard time initiating a bowel movement. So a lot of people will do like a suppository with a diaper change, and then poop comes out, and it's sort of a medication of convenience for that. One warning is that enemas in younger kids you want to avoid, like infants, especially under 6 months, but even under a year, I'm pretty hesitant, because some enemas have sodium phosphate, which can get absorbed by the lining of your rectum and can cause your phosphate levels to go up really high, which can be bad. And I've seen that happen a few times. So just something to be careful. In kids less than 1 year, I tend to just stick with the glycerin suppositories, because that's just like soap that you're putting in somebody's bottom. And then the one area that people tend to avoid a lot with pooping is to get a physical therapist involved. So I'd say constipation is probably half of my new patients, and almost every time they've tried a bunch of other stuff, but they haven't tried pelvic floor physical therapy. The hard part tends to be finding the right person. So for the most part, this is a specialty that has largely been used in postpartum women or in older women that have things like prolapse. But it's become a lot more popular over the past 2 or 3 years. There's more people that are used to dealing with special needs patients. And I think it's really helpful, but you got to find the right person, especially somebody that's comfortable dealing with somebody with alternate ways of communicating. And then behavioral interventions, also very important. The standard stuff that we tell people is you need to have a schedule for sitting on the toilet. And then you really only want to have positive reinforcement. You never want to punish, regardless of someone's developmental level, you never want to have not pooping result in any kind of negative consequence. You only want to make it an amazing place, like fill the bathroom with their favorite toys, and they can watch whatever they want in there, and the bathroom is amazing, and then just shower them with gifts whenever they poop. Any kind of negative reinforcement is only going to make things worse, so just keep that in mind. I think this is often helpful to do this, if your child is seeing a BCBA, is getting ABA therapy, really trying to do that in conjunction with them is usually a good approach. The last resort that we usually use as far as treatment is something called an antegrade continence enema. So MACE stands for Malone Antegrade Continence Enema. So antegrade just means it goes the same direction as your poop. And a continence enema is just something that liquefies all of your poop so it can come out easy. So this is like a little, like a G-tube or like a little port that we put at the very beginning of the colon, and then it allows you every morning to put a bunch of liquid in there and flush it out. So it accomplished the same thing as an enema if an enema could do your whole colon. And then ignore all of these numbers except for the top line. So this was a study where they looked at people that had a cecostomy, like a tube at the beginning of their colon. And they saw before the cecostomy, they had about 1 bowel movement a week. And after the cecostomy, they had 1 bowel movement a day. So these are very effective treatments. But it's a surgical intervention. It requires being managed in a center that really does a lot of these to make sure that it's safe and done correctly. But that's an option. There's a lot of PMSers that have MACEs or cecostomies. And if the right person gets them, they can really improve quality of life. Okay. So that's enough of the pooping. So this particular emoji is a lot more concerning. So the poop emoji, nice healthy poop, he's smiling. This emoji is vomiting green vomit, which any medical people can tell you that's bad. It's the wrong color of vomit. That means that there's bile in the vomit. So this emoji has a small bowel obstruction and absolutely needs to be seen by a surgeon like right away. So this is actually a pretty bad emoji. He's right to be very upset. And he's got like some kind of weird colored stuff in the vomit, and like some like Christmas ornaments. I'm not really sure what that is. Maybe that's the reason that he has a small bowel obstruction. Okay, so the same sort of phenomenon that happens in the colon happens in the upper part of your GI tract. So we have, the name we have for the colon in that whole area is called the hindgut. And that has a certain set of nerves and blood vessels. And then everything on the top part, like the stomach and the first part of your small intestine, is called the foregut. And that has a certain set of nerves. And the nerve that's really involved with everything that happens on the top part of your GI tract is called the vagus nerve. And it's involved with everything. As you can see on here, it's connected to like every single one of your organs. It's the main nerve that causes migraines. It's the main nerve that's involved with cyclic vomiting syndrome. It controls your heart rate, your blood pressure, the tone of your blood vessels. It controls nausea, vomiting, appetite, and of course, it's the one that gets out of whack the most often in kids that have neurodevelopmental disorders. So, and there's lots of things that can happen that can make you throw up or make you have GI symptoms. So the first thing is another muscle tone problem. So if you've got low muscle tone elsewhere in your body, you can have low muscle tone in the lower part of your esophagus. It's called the LES, or lower esophageal sphincter. That can cause reflux. You can have low tone in the muscles and nerves that make your stomach empty. It's called delayed gastric emptying or gastroparesis. You could have the vagus nerve could just be way too amped up, and every time anything happens, you just throw up constantly. Since it controls vomiting, if it short circuit, then the end result can be vomiting. You can have an exaggerated gag reflex. A lot of kids that have swallowing problems or things like that, any kind of texture can set off vomiting. So the nerves are just way too easy to stimulate, way too excited at baseline. You can have different ways of interpreting that information in the brain. So there's the area of your brain that controls vomiting has the best name of any part of your body. It's called the vomiting center. This is where the neurologists did a great job. And I really wish they would do it for everything else, right? Like the pooping center, the throwing center, the vomiting center. But it's an area in your brainstem that communicates directly with your stomach and tells it when to throw up. So when somebody is getting chemotherapy or somebody has a fever or somebody is sick or ingests a poison, then that's the information that gets sent to the vomiting center in your brain and says, let's get rid of the stuff that's in your stomach. Unfortunately, when your nerves aren't formed quite like they're supposed to be, or the connections aren't quite right, that's the vomiting center can activate when it's not supposed to. And so, that can be happening at the same time that lower esophageal sphincter tone is low, and there can be some gagging involved, especially if you start throwing up. Your stomach cannot empty too well to begin with, and that nerve that controls all of this can be out of whack. All of these things can be happening at the same time, and they often are. So again, we're back at this kind of this perfect storm sort of scenario where we can't say it's just one thing. It's probably happening from several different things at once, and we have to develop this approach that is much broader than the way that clinicians tend to deal with problems in general right now. So here's an example of a vomiting disorder really common in PMS. So this is cyclic vomiting syndrome, and it's a form of migraines that happens, it is not just PMS, it's in lots of different genetic neurodevelopmental disorders, where you have two or more intense, unremitting, and that's well written, it's like, this is bad, intense and unremitting, episodes of vomiting that happen over a 6-month period. They are stereotypical, which means that the person looks the same and that happens at the same time of day. It has the same sort of triggers. And usually parents will tell me, oh yeah, I can tell it's coming. He's gonna throw up. He looks pale or he looks off. And then typically there's weeks or months between episodes. But here's the problem. So to get this diagnosis, you basically have to have no other medical problems. So if you have any other medical problem going on that could potentially explain it, you can't really get this diagnosis. So this is another example where the diagnostic criteria that we have make it impossible to accurately diagnose children or adults that have special needs. So for instance, no other explanation for symptoms. What if they have epilepsy? What if they're okay, well, this could be from seizure? Or what if they're on 7 different medicines? Or what if they're having a behavioral form of vomiting? Then are we just going to say, oh, this can't be cyclic vomiting? So then this just gets back to the fact that there are probably multiple reasons that our kids have these episodes, and we can't stick to the single explanations that have been validated in typical patients. So how do we treat cyclic vomiting? So full disclosure, this is my favorite medical problem to treat, because usually what happens is that somebody has been to the ER 20 times and been told that they have a virus 20 times in 1 year. And they're like, Doc, I just don't think this is a virus. And I go, well, I think this is cyclic vomiting syndrome. And they've never heard of it. And we start them on a medicine, and then they're cured. And then I see them once a year, and they just go, we're just so happy. You're just a genius, Dr. Bennett. So these patients are how I feel better about myself. I don't let them know that this is really easy, and all of us see this kind of stuff all the time. So the the first thing that we really do if somebody has an episode of vomiting in general is give lots of fluids. You don't wait till somebody's dehydrated. If they have a G-tube, we put Pedialyte in it. If they're able to drink, we just have them chug Pedialyte, something that's got both water and sodium in it. And we give Zofran, probably my favorite medicine. It's like, it does cause constipation if you use it a lot though, so ironically. And it comes in an orally disintegrating tablet, so you can have it dissolve in somebody's mouth. Some of that will get absorbed even if you're actively throwing up. And then, we'll typically try to manage it at home, but if somebody's still having lots of vomiting, the next step is to go to the ER, get IV fluids, and get IV Zofran. And the problem people run into is that the ER doctor doesn't want to give you IV fluids unless you're dehydrated. So you have to tell the ER doctor, well, my GI doctor said, and even if you don't have a GI doctor, you can just say that I said it. Well, this GI doctor I heard talk said that you should do this. Because you're actually activating the mechanism to turn off this nerve. You're not rehydrating somebody necessarily. You're increasing the amount of fluid inside your blood vessels, which tells the vagus nerve to chill out. So you're not rehydrating. And that's an important thing to remember when you're dealing with vomiting, is that lots of doctors are going to say you don't need IV fluids because you're not dehydrated. Doesn't matter. Still give IV fluids. That can actually stop the vomiting on its own. And then we'll often use what we call maintenance therapy to prevent episodes of vomiting. So the biggest one is to avoid triggers. So car rides can be pretty common, certain smells, certain emotional situations can be triggers. So really trying to identify those are important. And then there's a few medicines that I like. Amitriptyline, also my favorite. It's an old antidepressant that was not a very good one. And now the only people that use this medicine are GI doctors for stuff like this and neurologists who use it for migraine prophylaxis. You have to be careful using this with other psychiatric medications because there can be some overlap with how serotonin is handled with SSRIs and SNRIs. But at low doses, I often have patients on things like Zofran or Prozac and amitriptyline, as long as they're both at low doses. Cyproheptadine is another really good one. It's an old antihistamine, not a very good antihistamine, but it's a really good vomiting medicine. It's also an appetite stimulant, so if you have an issue where a kid's not taking enough calories, this can kind of solve two problems for you. Propranolol, an old blood pressure medicine. You're noticing a theme in GI. We don't have our own medicines. We just steal them from other people. And then there's some supplements like coenzyme Q and L-carnitine, which usually not on their own particularly effective, but in concert with other approaches tend to be pretty effective. But why is this so much harder in people that have neurodevelopmental disorders? Vomiting is a very non-specific problem. There's all kinds of things, like med students hate vomiting because it could literally be anything. It could be an ear infection, or it could be, a bowel obstruction. And so really, how you approach it's really challenging. And so there are lots of other problems that come up with it. So one is that the medicines we use tend to affect part of your EKG called the QTC. If you have to use too many medicines that affect this at once, then you can cause an arrhythmia. So we have to be careful with which medicines we're using for these kind of problems. Lots of seizure medicines like Topamax or topiramate, we use that for cyclic vomiting or migraines all the time, but it's also a seizure medicine. Appetite stimulation sometimes is bad. So if we give somebody cyproheptadine and they're already overweight and they're just eating more pizza, we're just making problems worse. There's lots of other things that can make you throw up. Seizures can make you vomit. Having a VP shunt that's malfunctioning, having gastroenteritis, having behavioral causes of vomiting like rumination. And there's very little data, very few research studies to guide us on what to do here. And then, like I mentioned before, even the diagnostic criteria for this stuff is just validated in neurotypical patients. So what do we do? Oh, and I want to talk about one other thing that's come up. There's been a few patients in the community that have had really bad outcomes, that have often had a lot of change in how their GI tracts have functioned towards the end of their lives. And we don't really understand it. I'm sure you're all aware of a lot of the efforts that the Medical Advisory Committee has been taking to try to review a lot of these serious episodes of regression or neuropsychiatric collapse. But a lot of it is in concert with the GI tract just refusing to work, like a switch gets turned off. And it often starts with, you're vomiting more, your stomach's not moving, you have a G-tube placed, and then that's not working, and then your colon's not moving, and then, people just keep doing more and more things, and more invasive stuff happens. Oh my gosh, I'm going way too slow. And just as an FYI, if anybody has any questions afterwards, just come grab me. But this is, probably, and this is just my theory, but I think that what happens to a lot of our kids is that, we worry about regression, and we worry about catatonia, and these things that are probably neurological in origin. I think the same thing happens with the GI tract, where there's an event that we don't understand, where the nerves suddenly just go downhill. And it often happens in a relatively catastrophic way. I don't have a good term for it. It's not something that's well described in the literature, but it is something that we're trying to understand more completely. But my theory at the moment is that this is a component of all the other neurological things that can happen, especially that this is probably a form of regression that is more to do with the GI tract. So I don't have a lot of, and there's not anything specific to do, but I think this highlights how important it is to really, when there's a problem, to have somebody seen at a center with lots of experience. Okay, I want to briefly talk about CANDID, which is the Consortium for Autism, Neurodevelopmental Disorders, and Digestive Diseases. And Curtis said that it was something that I did, but it was, so Heidi Grabenstatter, who's one of the board members, and I were the PIs on the grant, but Heidi and Kate and Alicia Holliday did all of the work, and they very kindly gave me some of the credit. So I do not want to take credit for this. But I will note that there is somebody familiar to me who is in a photo on the webpage. So the GI survey was something we did a couple years ago over about a 3-month period. We had 717 responses, all done online. The main goal was to understand how GI symptoms affect quality of life. But the sneakier goal was to show how bad the measures are that we were using in our patient population. We got a lot of interesting feedback from families on how the survey went. It was called incredibly difficult. Hard to answer the questions, since most of our affected individuals are nonverbal. Interesting. Respondents tended to drop out because it was too hard to do. I just had to take a wild guess. I feel like my responses were garbage. So FYI, in the paper that we published to write this up, this was a direct quote that we put in the paper. So this is part of the scientific literature. So whichever among you submitted that, thank you. Most parents of neurotypical kids probably can answer these questions, but those of us who can't, that just makes us feel further marginalized. Like we can't even gather data on our kids. It's very frustrating. The recall time, it had to be in the past 7 days. I can remember about the past 24 hours right now. And the takeaways from this really were that we need to involve families more. And whenever we're coming up with instruments, and these are not things that I invented, these are just existing validated ways to measure GI quality of life that we just threw into the survey. But they were all validated in neurotypical people and didn't take into account medical complexity or burden on the person answering it, or whether or not the person was verbal or not. And so the main thing that I got from it personally was that, we could answer maybe 30% or 50% of the questions. And the first thing that tells us as parents is that makes it feel like our kids are like partial. Like we're only able to give data on part of them. Like they're just part of being a human being. And that's something that we're reminded of a lot. And the next step that we really need to take is that we need to, gather data, but do so in a way that doesn't tell us over and over again what our kids can't do, and focuses more on what they can do and what steps we can take to improve their lives. And Ronnie mentioned this last night about the red hair, and unfortunately the data do not hold with this. Brown hair wins by a landslide. I'm very sad to say. And here's the scorecard for number of respondents to this survey. And the text is pretty small, but you can see that PMS, the other category won, but of those that had a diagnosis, PMS, clearly the leader. Very proud of you guys. I showed this to you before. Constipation was sort of the dominant thing. I'm going to skip over a lot of this, but basically the takeaway is that of the data we did get from these quality of life instruments, so it should be about 88 on the scale. But you can see all of this is pushed way to the left. And that means that there's lower quality of life associated with GI symptoms. And this is just over like different ages. You can see that none of it is centered around 88, where it should be for somebody who's healthy. And I said that here, 62 was the median, but it should be 88 for healthy children. So this tells us that there's a substantial amount of quality of life affected by GI symptoms. This is a different scale where the same thing happens, but normal should be 50, and the higher it is, the worse off you are. As you can see, all of these, different symptoms, all are to the right of 50, meaning there's more suffering going on from all these different things. I'll skip over some of this. Okay. I'm going to end with some unsolicited advice because I have like 2 more minutes and you sort of have to listen to me. So in relation to GI stuff, avoid excessive antibiotics. There's good data that something like 95% of antibiotic prescriptions are not for a bacterial infection, and antibiotics really mess up your GI tract. So avoid them if you can. And you can take a probiotic most of the time when you're taking an antibiotic to improve most of the side effects. Avoid overuse of procedures. So somebody shows up to the ER with abdominal pain, they're often getting a CT scan. That happens a few times and you got a lot of radiation. So our kids are complex, our kids have a lot of medical problems, they're vulnerable for all of the side effects that can occur from overusing medical care. So just be wary of that. Avoid the ER if you can. Nobody loves going to the ER. If there's an emergency, they are great. If it's a chronic problem, they are not equipped to help you nearly as much as just getting in with a good outpatient service related to that. I would love it if diet fixed all this, but it does not. Yes, you need plenty of fiber. Don't eat hot sauce with every meal. But in general, most people cannot fix the whole problem with diet. Vaccinate your kids against preventable serious GI problems. So rotavirus and hepatitis both have vaccines. PMSers are going to be more vulnerable to this. COVID also can cause a lot of GI symptoms. Be really careful when somebody tells you that they have a cure for you. And if it's a simple cure that they also happen to sell, like it's a supplement or a dietary change, we're like, oh, what is this dietary change? It's all outlined in this book that costs $25. So just be really careful. It's very easy to be taken advantage of when you're desperate. And some of them are right. There are supplements that work great, but That doesn't mean that the person giving you the advice isn't trying to take advantage of you. So just always be careful. And be skeptical of people in my profession too. Make sure that they know what they're talking about. Make sure what they say makes sense. Okay, last slide, I promise. Our children are unique. Most doctors have never seen Phelan-McDermid syndrome even once. I've had the pleasure of talking to 100 plus of you on the phone or in conferences. I've got 10 or 15 PMS patients that I see personally, some of which are here. Most people don't have that level of experience. And if you have a hard problem, work really hard to get advice from somebody that really has that experience, because this is a rare disorder. And if you don't like the advice that you're getting from a doctor, go to a different doctor. We see some doctors at the hospital where I work. We see other doctors at other places because we feel like they're going to give us better care and better advice. And it's okay to do that, and don't worry about what the doctors or nurses think. This is your kid. Don't worry if you hurt their feelings by getting a second opinion. This is your kid, okay? And then in the end, everything is a balance. Every decision you make is going to have some potential for harm and some potential for benefit, and you're often not going to know what they are. And because all these kids have a rare disorder, usually there's no data, there's no research that says it's safe or not safe, or it works or it doesn't. So, it's always on us to make that decision on, what is the risk benefit. But you get to decide that. It's your kid. You get advice from different professionals, but it's still your decision. And just always remember that it's impossible to do something with zero risk, and it's impossible to do something that works 100% of the time. And that's hard, and that sucks, and it's frustrating, but that's not going to change. But it's still up to you. And I would be happy to answer questions. I'm sorry, Kate, please don't be mad at me. I went way over.
Not at all. We actually have a good amount of time for questions, about 10 minutes. So thank you, Dr. Bennett. I think that was extremely engaging. I'll start with a question we have from the virtual platform. You mentioned Miralax, and I've seen some families report behavioral issues with Miralax. Have you heard of that? Is there any concerns there?
Oh, so this is probably the question that I get asked most in every aspect of my professional life. And it's a hard question to answer, because on the first hand, I don't want to invalidate anybody's experience with a medication, especially how it affects their kids' behavior. So when my patients say that they're concerned about Miralax or that they had a problem with Miralax, we just try something else. There are plenty of options that are like in the musher category. As far as whether or not there's good evidence of that, there was a study done, one at Nationwide Children's in Columbus and one at CHOP in Philadelphia, neither of which showed that anything was absorbed into your body from Miralax. So it's probably not Miralax that's causing it, but I don't push it with people, and I say, if you experience that or you're worried about it, let's not even bother. Let's try like lactulose or magnesium or something else.
Thank you. We have a very popular question about over-the-counter medicine for reflux not seeming to be working well. Gave examples of Prilosec, omeprazole, and what would be next steps if there's still lots of burping, gas seems to be uncomfortable, uncontrollable?
So I didn't even touch on reflux. That's like a whole talk by itself. So PPIs like omeprazole tend to be the most effective. Often what we have to do is increase the dose because that lower esophageal sphincter in people that have a neurodevelopmental disorders tends to be looser, easier for acid to come up. So really trying to maximize how much we reduce the acid. Then the next thing I typically do is add in like a medicine for breakthrough reflux, like Pepcid Complete is a combination of Pepcid and like a Tums type antacid. That usually works well for breakthrough. The other thing that we often do is look at, yes, there's reflux, but is the stomach emptying well enough? So in a lot of my patients that have neurodevelopmental disorders, I'll also add in something like erythromycin, which helps the stomach empty faster, because you can reduce the acid all you want, but it's just plumbing. If there's too much pressure in the stomach and stuff's just going back up, it's still going to go back up, whether it's acidic or not. So we usually have to have kind of a 1-2 punch there, where we reduce the acid, but also help the stomach empty better.
Has there been a high correlation between gluten intolerance or even celiac with Phelan-McDermid?
I have not seen it. It has not been extensively studied. I've scoped maybe 9 or 10 kids with Phelan-McDermid syndrome. None of them had celiac disease. I've probably looked at maybe 20 or 30 blood tests for celiac disease, and maybe 1 or 2 of those were positive. But that's not even remotely systematic way of gathering the data. But it's a fairly common, celiac disease is really common, anywhere between 1% and 5% of the population. Gluten intolerance is probably 10 or 20% of us. So unless we really saw a massive amount, I would say that kind of stuff is probably about the same as the general population, which is high for both. And that being said, avoiding gluten, perfectly fine. And it's easy to have a healthy diet with a gluten-free diet. And it's way easier than it used to be, thanks to Whole Foods and places like that. So if people want to try it, I don't even hesitate. It's a much easier diet to do these days.
Thank you very much. We have a highly voted question. My daughter has the opposite of constipation. She poops every night in her diaper and never in the day, and it's very loose and often diarrhea. Have you seen this issue in Phelan-McDermid?
Okay, this could also be a whole other talk. So I think that what happens in people that have neurodevelopmental disorders, especially if there's autism, is there's a much higher rate of irritable bowel syndrome. And so the variant of irritable bowel syndrome that causes diarrhea, very well named, IBS-D, that we'll often try like IBS medicines in this situation. So one thing that we'll do is we'll avoid things called FODMAPs, which are simple sugars, FODMAP. They're simple sugars that are in a lot of different stuff, like lots of healthy foods, but also lots of processed foods. We'll try antispasmodic medication, so things like Bentyl and Levsin are what we use most often. But what I've really leaned towards recently is doing the newer IBS medicines. There's one called Aloxadoline that is specifically FDA approved for IBS-D, and it's actually really good at reducing diarrhea. Hasn't been tested really at all in kids that have neurodevelopmental disorders, but I usually think that's the kind of thing that's worth a try, because I think IBS is more common in our kids. However, diarrhea has 50 more causes. I think that's probably the most common cause and typically the first thing to think about.
I don't know all the names of medications, so I hope I don't mispronounce this, but 10 people are wondering if Linzess is a good option for constipation.
That was the perfect transition. That's one of the newer IBS medicines. So that one is for IBS-C. And Linzess is linaclotide, and it's quite effective, but again, has not been tested. So I do think a significant portion of kids that have constipation really have a form of irritable bowel syndrome. So that's another medication that we have in our toolbox, and I've used it quite a few times in this kind of situation. So short answer to the question, yes, usually worth a try.
We are at time, but I'll do a couple more questions just because there's still a lot of good ones. When is it necessary to take my 3-year-old to the doctor for not pooping? Sometimes it's 2 to 4 days before a bowel movement and she strains.
What was the first part of that question?
When is it necessary to take my 3-year-old to the doctor for not pooping?
So it isn't necessarily the amount of time. It's more like how is the constipation affecting their functioning. So if you're not pooping and then you're not eating, you need to be seen. If you're not pooping and you're throwing up, you need to be seen. And generally, like, once you hit a week, I'm like, yeah, we should probably talk. It's not the same thing as a bowel obstruction, though. It's just dry poop accumulating in your colon. So in most cases, being more constipated is not a medical emergency, but something does need to be done. And usually, if my patients call me and they haven't pooped in a few days, they are almost always getting a Miralax clean out. So a lot of my patients will just keep the handout that I gave them last time, and then instead of calling me, they'll just do a clean out. And then if that doesn't work, then but usually it does. So that's, it isn't just about when do you talk to the doctor, it's about talking to the doctor and having a plan, a contingency plan for what to do. Like if you have asthma, then you go to the doctor, you get an asthma action plan. What we need are constipation action plans. And there's some offices that do that, and it's kind of like, oh, you don't poop for a day, you get this. You don't poop for a week, you get this. So really having that laid out from your doctor tends to be a good idea.
All right, last question, and hopefully you know this acronym because I don't, but how much PEG is too much? Are there limits or can it be harmful?
So PEG is Miralax, polyethylene glycol. And that's just the generic term. So we use utterly massive amounts of it to do a clean out before somebody has a colonoscopy. And then whenever we want to clean somebody out for like bowel surgery or just to get constipation under good control in the hospital, we put an NG tube in and just go lightly in, which is just liquefied, like it's just Miralax that's been already mixed up. So none of that gets absorbed by your body. It's this long molecule that just holds on to water, and all it does is flush out poop. So about the worst that's going to happen with too much polyethylene glycol is that you're just going to poop a lot. But usually that's why you're taking it. So, I want to reiterate, I consider it to be a perfectly safe medicine. I'm perfectly comfortable giving it to any of my kids in perpetuity, but there's lots of other choices. Magnesium is the other, good one for cleanouts. So I don't push back at all. If somebody's uncomfortable with a medicine, I don't really want them to give it to their kid unless we have no other options and they truly need the medicine.
All right, perfect. Well, please join me in thanking Dr. Bennett.